Hello, everyone. My name is Crystal Anderson, and I'm the Director of Clinical Informatics here at HIMSS, and I'm pleased to welcome you to our second Pharmacy Informatics Town Hall series. Today's session will be on medication history for hospital settings, better data and better decisions. Today's program will explore the availability of comprehensive and accurate medication history. Gathering good medication history is essential for effective management of patient safety. More comprehensive data, electronically available through EHR systems, can improve medication reconciliation across transitions of care. Today's program will explore what can be done to leverage software and data services to improve patient safety. Our speakers will explore how to efficiently access comprehensive electronic medication history in hospital and acute care settings. Lastly, the impact of implementing electronic medication history for medication reconciliation across health systems will be discussed. Please be sure to submit questions using the Q&A function on the right-hand side of your screen throughout today's program. We have several pre-test questions for you this morning. Please utilize the open polling function on the bottom right of your screen to answer the pre-test questions. Our first question is, does your organization use or offer some type of software for medication reconciliation? And the second is, which of the following is your biggest concern regarding medication reconciliation? Please choose the most important. As I mentioned, the poll will close in 5 minutes, and the results will be displayed once the poll closes on the right-hand side of the screen. NCPDP serves as our co-collaborator for today's event. Founded in 1977, NCPDP is a non-for-profit ANSI-accredited SDO with over 1,600 members representing virtually every sector of the pharmacy services industry. NCPDP members and leaders have created standards such as the Telecommunications Standard and Batch Standard, the Script Standard for e-prescribing, the Manufacturer's Rebate Standard, and many more to improve communication with the pharmacy industry. You can find out more information about NCPDP by visiting their website at www.ncpdp.org. Thank you to NCPDP for collaborating today's event. SureScripts serves as our town hall sponsor. Formed in 2001, SureScripts has evolved into a comprehensive clinical network. SureScripts connects pharmacies, payers, pharmacy benefit managers, physicians, hospitals, integrated delivery networks, HIEs, and health technology firms to enable the efficient and secure exchange of health information. More than 500,000 prescribers and 600 EHR applications and 94% of community pharmacists are active on the SureScripts network. For more information, please visit their website at www.surescripts.com and be sure to follow them on Twitter at twitter.com/SureScripts. Thank you to SureScripts for sponsoring the Town Hall series. HIMSS is the other collaborator of this event along with NCPDP. HIMSS is a global, cause-based, non-for-profit organization focused on better health through information technology. We lead efforts to optimize health engagements and care outcomes using IT. For more information, please visit our website at www.hims.org. Today we'll have 3 speakers. Our first speaker is Rochelle Shelley Spiro. Shelley Spiro is Executive Director of the Pharmacy HIT Collaborative. The Collaborative is an organization of the major national pharmacy associations and associate members focused on advocating and educating key stakeholders regarding the meaningful use of health IT and the inclusion of pharmacists within a technology-enabled integrative healthcare system. The goals of the collaborative are to assure pharmacist services through health IT are accessible, can connect, and support national quality initiatives. Please visit www.pharmacyhit.org to learn more information. Our second speaker is Ken Majewski, who serves as the Vice President and Product Support of SureScripts. Ken has over 30 years of healthcare experience. He received a doctorate of pharmacy from the University of Minnesota. He has experience in e-health, managed care, transplant services, pharmacy mail services, medical devices and drug delivery systems, home infusion therapy, and hospital as well as retail pharmacy. Our third speaker for today is Lee Mork. Lee Mork is Director of Ambulatory Pharmacy Systems for Allina Health. In his role, he is responsible for several of the clinic's programs, including Pharmacy and Therapeutics Committee, Medication Policy, Pharmaceutical Purchasing, Medication Storage and Handling, and a Medication Assistance Program, as well as e-prescribing prescription technologies for 72 primary care clinics. Lee has 15 years of experience in the pharmaceutical industry and prescription benefit management industry. And now I'll turn over today's presentation to Shelley.
Well, good afternoon. We're going to start out with talking about the industry and regulatory and policy perspective. So really, why is medication history important? If you can go to the next slide. If we look at medication history or even medication information, as our patients go from their home and are admitted into the hospital and then discharged and then back home, we see that medication information flows with that patient. And reconciling that medication history and that medication information at different points when that patient is either admitted or discharged from the hospital is really a critical point in patient safety. If you go to the next slide. Nope, there you go. In terms of what we see in terms of a manual process, so as an example, if a patient would bring a medication list or a spreadsheet of the medications that they're taking, this manual process of actually taking that information and putting it into an electronic process is extremely inefficient. If you go to the next slide. When we talk about medication information flow, we really have different sources of where we receive medication information, especially electronically. So we take that information, we share it, we collect it, we put it into an electronic form. This is really medication history. And that could be whether it's from claims-based information coming from a payer or whether it's sitting within an electronic health record. One way or the other, that information is collected in terms of medication history. When, as providers, we take that information, we evaluate it, and we change that information, that medication information, that's medication reconciliation. So we're doing something with that information, and then it becomes a trusted source, and the sharing process begins all over again. Can you go to the next slide? There are different sources of medication history outside of what we would normally term of whether the patient is just giving us a list of their own medications or whether we're receiving an actual electronic medication history. We're seeing a movement towards electronic personal health records. And this is in terms of one of the Office of the National Coordinator for Health IT or ONC's Blue Button Initiative. The Blue Button Initiative is a way to actually download medication record information, including medication lists or the active medication list that a patient is on. And that can be downloaded from a pharmacy that goes to an electronic health record or downloaded from the patient's electronic personal health record to a hospital or to a physician's office. So there are many sources that are out there outside of our typically of what we would consider where medication history would stand. So for the future and going forward, we need to make sure that we look at these methods, again, going back to what is the source of medication information, especially medication history information, what's the source, and then is it trusted, has it been reconciled? If you can go to the next slide. The Joint Commission, which actually accredits hospital organizations, in 2005 as part of the National Patient Safety Goal 8, actually tried to incorporate accreditation process for documenting medication, an active medication list, especially at the times of transition when that patient is admitted into the hospital setting. It was a very manual process, and over the years, actually the Joint Commission stopped that process because it was so cumbersome for the hospitals to actually implement it and measure it appropriately. So as the hospitals began to adopt electronic health records and adopt more electronic processes, in July of 2011, the Joint Commission, as part of the National Patient Safety Goal number 3, started up the medication reconciliation process again. And this was even extended in January of 2014 as part of the National Patient Safety Goal 03.06.01. They actually incorporated obtaining the medication history information at the time that the patient is admitted into the hospital or actually into an outpatient setting. And then also the Joint Commission further made sure that the providers are providing the medication history information or the active medication list at the time that the patient is discharged from the hospital or when they have finished their outpatient encounter. All of these are important aspects from a regulatory standpoint of actually how we begin to, from a patient safety aspect, incorporate medication history and even medication reconciliation in the whole process. If you can go to the next slide. So there are some guidance material that are out there from the American Society of Health System Pharmacists has actually put out a statement in relationship to the role of the hospital pharmacist in medication reconciliation. I put the link on this particular website, and I encourage especially our hospital pharmacists to look at this statement because it really explains what we need to do as pharmacists in terms of medication reconciliation. Go back one, please. Go back to the previous slide. Also, another guidance document came from the American Pharmacists Association and the American Society of Health System Pharmacists. They put out a guidance document in terms of optimizing medication reconciliation during the transitions of care process. They actually came up with 8 foundational concepts that really go into some of the standardization processes, what we should really do from a medication reconciliation standpoint. It's a really good document. I did put the link on that particular website. It was actually published in March of 2012. If you can go to the next slide. In terms of standards, Health Level 7 actually has a EHR functional model that all electronic health records work off of. There is a project, there was a joint project between HL7 and NCPDP that actually created an HL7 pharmacist pharmacy provider EHR functional profile. And it really helps facilitate the capture of medication and comes up with the functionality and the conformance criteria of what should go into a pharmacist EHR in terms of managing medications. If you can go back, please. One slide. Also, in terms of this particular standard, Direct Care 1.4.2, which is an essential now portion or a conformance criteria under the HL7 functional profile, it talks about managing a medication list and also how to create and maintain patient-specific medication lists. If you go to the next slide. Now, in terms of some of the regulatory processes that are out there, when we talk about meaningful use stage 2, which really went into effect October 2012, for eligible hospitals and critical access hospitals. They have core measurements. Actually, the core measure 11 out of 16 deals with medication reconciliation. And they say that it should be performed when receiving a patient from another care setting or receiving a patient from another care provider, or when you even believe that that encounter is a relevant encounter. Also part of the meaningful use stage 2 portion under for eligible hospitals and critical access hospitals, they also talk about electronic prescribing, and that's a measure in 5 of 6, which talks about generating and transmitting permissible discharge prescriptions electronically at the hospital level. And in order to create an electronic prescription at the time of discharge, it's really important to have that medication history available to that provider or that prescriber prior to writing the discharge information. And so this is where an electronic version of medication history becomes very important also. If you go to the next slide. Now, as we move forward with Meaningful Use Stage 3, and for the Meaningful Use Program, of course, it's a Meaningful Use of Electronic Health Record Program, which is a program for hospitals and physicians to receive incentives under the Centers for Medicare and Medicaid Services. So as we move forward, what's being proposed for eligible hospitals and critical access hospitals is a medication history for adherence monitoring. Now, again, this is proposed, and it's really to do a connection to the pharmacy benefit managers to retrieve external medication fill history for medication adherence monitoring. So as we see things moving forward, medication history, especially in electronic format, is going to be very important. If you go to the next slide. Now, lastly, from a standard standpoint, we have the NCPDP Script Standard 10.6, which is the standard for e-prescribing. And it talks about really what we need to do from a communication standpoint with prescription information between the prescriber and the pharmacy. Medication history information is an important portion of that, and it needs to be done electronically to follow the actual script standards. So it's not a fax and it's not for paper. On the NCPDP website, they have a really good document fact sheet dealing with medication history. Now, from a pharmacy standpoint, a pharmacy can actually initiate a med history request to a prescriber. It could also initiate a med history request to a payer or other entity. From a prescriber hospital standpoint, you can also initiate a med history request to a pharmacy. You can also initiate a med history request to a payer or other entity. So when they say initiate, that means that they can request that med history electronically from those entities. So we look at all entities such as pharmacies or prescribers or hospitals or even the payers themselves. Med history can actually be requested. And also they can provide med history, especially in its electronic version. So if you go to the next slide, I'd like to turn the session over to Ken, who's going to be talking about real-time medication history for transitions of care.
Thank you, Shelley. And I'll greet all of you with good morning rather than good afternoon. Shelley's on the East Coast. Lee and I are in the Midwest, so we're still getting through our morning. But thank you for joining us here today. What I'd like to do today is talk to you about real-time medication history for transitions of care, specifically what and how we provide medication history to probably 1,000 hospitals today at the point of admission, to hospitals and EDs, and then to those, I think we're up to about 575,000 e-prescribing providers who can also access medication history through their e-prescribing application. We know that we have an issue and a problem. More than 40% of medication errors on average result from inadequate medication reconciliation. over 770,000 people die or are injured annually due to adverse drug events, and 23% of patients readmitted within 30 days have an adverse drug event as either a primary or a secondary diagnosis. And with the change in healthcare reimbursement, the whole issue of readmission is probably, if you're from a hospital or an IDN, is probably a key initiative in your institution today. Next slide. What we provide from SureScripts is a real-time electronic feed to electronic health records and other certified technology vendors who have medication reconciliation products and services. It's purely a data feed. It provides a broader view of the patient's medication history, specifically prescription history, medications which require a prescription, and I'll get a little bit more into the detail about that. We offer a relatively extensive view into both PBM claims data as well as pharmacy fill data. So we have multiple sources that we collect information from and provide in real time. What I mean by real time is literally at the point of admission, and we'll go through the transaction set specifically, but literally at the point of admission, when the request is made through either the electronic health record or the certified technology vendor, we're usually able to get medication history back within seconds. There are obviously some different latencies at different points in time, and as we look at things, we usually have an internal routing of 2 to 3 seconds with other latencies. I would imagine this is mainly getting back to IDNs in somewhere between 5 and 15 seconds, and maybe I'll let Lee address that a little bit later, but it is a real-time feed. Next slide. The sources for the medication history are twofold. SureScripts has 2 master person indices that it queries. One is the PBM master patient index, and in that are 250 million plus covered lives from the PBMs who participate in as stakeholders in e-prescribing and medication history services. We also have a pharmacy database of about 2 billion prescriptions collected from a variety of pharmacy, retail pharmacy providers, representing about half the prescriptions filled in the United States in the last year. The latency of this data is relatively low. The PBM medication history has virtually no latency as a prescription is adjudicated and gets into a claims database. It's queryable. The pharmacy database is data sent to SureScripts on a nightly basis that needs to be formatted and put into a database and put into the master person index. I would say the pharmacy database probably has a latency of somewhere between 24 and 48 hours. So it's pretty fast data. The data fields are there for you to review. Those are the basic data fields in the NCPDP medication history segment for medication history. Probably the only difference between the PBM data and the pharmacy data is that with pharmacy data we have the SIG. The SIG is, as you know, the instructions. Take 1 tablet twice a day. Take 1 tablet at bedtime. Claims data does not have a SIG associated. Rather, it does have the day's supply and the quantity, so that oftentimes that could be intuitively calculated, but the SIG gives you, from the pharmacy data, a little bit more precision as to how the drug is meant to be taken by the patient. I refer this, what we send is up to 1 year of active medication history. I refer to this data feed as that little electronic brown bag of medications you really wish the patient had brought with them. And the key thing is like that little brown bag that a patient would bring with them at the point of admission, a clinician still needs to pour the bottles out of the bag, look through them, make sure the right pills are in the right bottle, and there aren't multiple pills or someone else's pills in the bottle. And that's true with the digital feed as well. It's absolutely important that the clinician make sure that they identify that they're talking to the right person with the right medication history in front of them. This tends to be the medication history of what is prescribed, and it's a precise, accurate, and longitudinal feed of how a patient either uses their benefit to purchase medications or how a patient purchases medications at pharmacies that participate in this service. It doesn't have OTCs and nutraceuticals. If the pharmacy doesn't know you have a benefit, then when they're doing a low copay, a lower than lowest copay, or a $4 generic, it may not get into a claim database. Usually, if a pharmacy knows you have a benefit, they will adjudicate it. But it's not the be-all, end-all. It's a very, very good start to the process of medication reconciliation. Let's go to the next slide. This is kind of a build slide, and I'd like to take you through the transactions and the actual workflow of what happens. When a patient is admitted to the hospital or to the emergency room, next, a HL7 ADT transaction is generated. What we're looking for in that ADT, and we're looking for specific segments that relate to admission to hospitals and EDs, but what we're looking for in that ADT transaction is demographic information that helps us identify that patient within the various master person indices. So we're looking for first name, last name, date of birth, zip code, and gender. We open that transaction and we query the two master person indices. If we find the patient in the PBM master person index, we reformat or translate that request into an NCPDP medication history request. We also, if we find the patient in the pharmacy master person index, we also translate that into an NCPDP medication history request. Next, we send those requests to the payer or payers the patient may have. Patients, about 15 to 20% of the patients in the country have multiple payers due to multiple benefits or carve-outs, etc. The claims database at the PBM and the pharmacy database returns a medication history response. So next, we aggregate those medication history responses, next, and we retranslate those, next, into an HL7 transaction that we send back to the hospital or to the technology vendor in the hospital or the emergency department, next. We translate back into two different HL7 formats. One is an ORU, or an 80-character per line blob. This was an early transaction we did back in the mid-2000s when there wasn't much application functionality related to medication reconciliation. Today, the majority of our technology vendors receive what's called an HL7 RDS transaction. This is a discrete data transaction that allows them to take that data and then reformat that into their product. The technology vendors then add the functionality of using drug databases, perform drug utilization review, perform medication possession ratios, or other functionality that allows them to compete in the marketplace with their products. I did say this is a precise, accurate, and longitudinal view of medication history, so we do give claims and fills over a period of time. So you can literally tell that a patient who is been prescribed an antihypertensive bought their 30-day supply on June 1st, July 1st, August 1st, September 1st, and October 1st, or you can tell that that patient bought their 30-day supply of their antihypertensive on June 1st, July 24th, September 23rd, November 5th, and that if they're in your hospital and emergency room because their blood pressure is high, that may have an impact on how you decide to move forward on treatment. Let's go to the next slide. We feel that the medication history addresses some key pain points for hospitals. I'm not going to go through all of this, but there are a couple key things I'd like to point out because it relates to not only the current guidelines for meaningful use and joint commission, but as Shelley pointed out, the fact that this information is longitudinal will help with potentially meaningful use 3 objectives. Additionally, I point to the very first one, the ability to repurpose this information at the point of discharge in order to help prevent hospital readmissions, to me, makes this information all the more valuable. If you think about getting a medication history, an ambulatory medication history, to start the medication reconciliation process at the point of admission, which, and the reason we built this product is pharmacists told us that was the most difficult transition of care to document. That medication, ambulatory medication history, doesn't change during a patient's hospitalization or stay in an emergency room. As a patient is getting ready to be discharged and discharge medications are being written, it would be highly valuable, in my opinion, to go back to this medication history that was received on admission to help with the discharge process. Because, in fact, if you think about it, those are the medications that are sitting in the patient's home. So when a patient comes into the hospital on a angiotensin inhibitor and they're on their PBM formulary medication, they come into the hospital's got a different formulary, they get placed on a different product. The discharging physician or hospitalist now is writing prescriptions, and they have the ability to see that if they're prescribing the hospital formulary-based drug versus the PBM formulary-based drug, the patient may actually have an angiotensin inhibitor agent at their home already. And if you're looking for reasons for adverse drug effects post-discharge leading to readmission, blood pressure pills antihypertensives are a perfect example of where patients run into trouble. There are obviously other medications as well. Next slide. We worked with a group in North Pittsburgh at an emergency room to look at, how valuable is this medication history at the point of admission to an emergency room. This was just basically a small time motion study done over several months. And basically what they were able to document is that at the time of getting an electronic medication history versus what medication history could be collected from the patient, they got about a 30% improvement in the completeness of the medication history that would normally take them 20 minutes to get. So a nurse taking a medication history, spending 19 to 20 minutes, would come up with a medication history that was about 30% less complete than what they got digitally. Additionally, they found that in order to get from where they got after 20 minutes to where they could have gotten with the digital medication history, they were able to find that it took an additional 19 minutes over and above the first 30 minutes in order to get to that level of completeness. In average, we think, and this is dependent on how patients utilize multiple pharmacies, multiple physicians, again, whether they have a benefit or are using a pharmacy that participates, we think we could get about a 75 to 83%, maybe a little higher depending on the area of the country, completeness of medication history at the point of admission. If we go to the next slide, we've basically taken those metrics and looked at, for example, the total number of discrete admissions to hospitals and emergency rooms and multiplied those by the time saved times the dollars associated with that time from a hourly wage point of view times what we think is a relatively appropriate hit rate when we get a request, and then dividing that by the total hospital beds. We think that for cost of time alone, the return on investment here, the cost is about $1,100 per bed. If we add in the cost of the adverse drug reactions and what they cost related to their incidence, we think there's an additional $500 that can be saved per bed per year utilizing a digital medication history. Next slide. One of the other things the study showed is what were the kinds of drugs that patients would often forget to tell a clinician at the point of admission. And it was very interesting that Analgesic central nervous system drugs played a heavy part on this. Antibiotics about 50% of the time. Cardiovascular drugs about 11% of the time. As a pharmacist, I look at this list and, these are the drugs most associated with drug interactions. These are the drugs that are sometimes taken episodically that patients don't remember that they're taking and don't admit to taking on a routine basis, yet can have a large effect on how that patient may be treated going forward. So it was a small study, again, time motion study, but collected some relatively interesting information as to what the impact of a digital medication history could provide. Next slide. So at the end of the day, we have a higher quality and higher efficient medication reconciliation process. We hope we're providing information that reduces the risk of adverse drug reactions. We hope we're supporting meaningful use in Joint Commission objectives and hopefully supporting objectives that are going to be coming out for Meaningful Use 3. Next slide. At the end of the day, we've got a solid infrastructure that has delivered medication history and prescriptions for 10 plus years to 600 plus electronic health record applications across the country. We deliver millions of medication histories a day to certified e-prescribing applications and to our certified technology vendors at hospitals across the country. We passed 6 billion transactions just in 2013. We're connected and maintain connections to 50 data sources across the country. We're both ENAC certified as well as ISO 27001 certified. And I mention that because of how important the security and privacy issues are in transmitting this data on a routine basis. I'm going to end my remarks there and now introduce Lee Mork, Director of Pharmacy for the Clinic Division of Allina Health.
Thank you, Ken. Hello, everyone. Thank you for joining us today. I'm very excited to talk about our experience at Allina as an integrated delivery network. Next slide, please. So Allina Health, it's made up of 12 hospitals. Integrated delivery network is part of that. 24,000 employees, over 5,000 physicians both employed and referring in physicians to our hospitals. We've been using e-prescribing tools since 2011. We've got the e-prescribing technology up for obviously prescriptions out, e-refill coming back in, and e-for request. We've got formulary and benefits, so daily we can see the formulary information coming through from payers. And we've had the medication history up for the outpatient clinics first, and then we moved into the acute hospital care setting a little bit later after that. We've been using it in the hospital since 2011, so we've got some fairly extensive experience using the tool at this point. So as we began the journey for basically looking at tools for the e-prescribing side of things, we started looking at kind of our med rec process at the very beginning. And in the beginning, we had our nurses doing our med rec. And they have certainly experience with medications, but not extensive, broad experience of all medications. So we would have patients bring to us, yeah, I'm taking a blue tablet, and can you define what that is? And not really, but it's blue. And so we had some mismatches on that. We also have patients basically telling us it's cyclobenzaprine, and the nurses would try to bring that in to the record and try their best attempt at that. And there is functionality that allows them to type that medication in without having the drop-downs come down, and they could add a medication that was misspelled as well. So really we wanted a better process for the nurse to be able to bring that medication in. We wanted a faster way to do that. We can do a patient interview and get some information. We may even call the pharmacy to get information, but we really wanted a more efficient way to do that. And we're also on the clinic side, we wanted to better understand our patients and the meds they were taking. Traditionally, basically, we would write an order, it would appear on an EMR, but the missing gap has always been, have they taken that medication? Did they fill that medication? And frequently, 20% of the time, patients don't fill medication to really prescribe to the prescriber. So it's very important for us to know that. And so we really wanted to have more complete history on the clinic side as well. Next slide. So we started looking at what we were doing and wanted to really make a case for why medication history on the hospital side would be important. We wanted a better, more efficient process for doing our med reconciliation. And we thought that we could use electronic tools to help us with that process. The other thing, in the state of Minnesota, as of January 1st, 2011, there was a state mandate to put e-prescribing tools in. And as we looked at the mandate from the state and looked at what tools they wanted, we felt it clearly did include medication history as part of what the standards were, and so we had to drive towards getting into our systems through that. We also knew that there's many situations, for example, of you've got a hypertensive patient in front of you, you're considering adding a third hypertensive medication because blood pressures are still up, you kind of wonder what's going on, and we knew that if we had the dispense history in front of us, we could have that really frank conversation with the patient saying, hey, it looks like you're not, according to what our records show, you're not filling those medications. We're attempting to add a third medication now to help you with blood pressure. We can see that you need some help with your medications. How can we help you better take your medication on a regular basis so your blood pressure is not up? So really kind of need the clinical benefits to help us drive that situation. So overall, management was impressed how we can display the information and how it can be easily added to the chart as we did our MedRec through the processes. Next slide. So just, our experiences that we added it in 2011, and just this is kind of my experience of doing these kind of projects, and some tips for you guys as you get into it with your organization. These installs are not plug and play, unfortunately, and really requires a team to get together to help install the technology. Which was easier to install, but really does involve a lot of work, at least with our EMR vendor, on the basically the customer side to do this kind of thing. So it's a big project. There are many tools that EMR vendors provide to help you with that, including tip sheets for install, options you need to consider, as well as timeline documents. So I would definitely take advantage of those as you get through it. For this kind of project, when it involves multiple teams in different areas, we'll get a project manager, and I would definitely recommend that for this project if yours isn't as plug and play. It really helps to kind of keep the project on task, keep resources assigned, and really move things along. We had a core team that was made up of pharmacy, nursing, physicians, and our IS partners to develop it. Really key to get your end users involved so they understand how the technology works and can provide feedback, as well as end user testing when you kind of get your process built to make sure that it works efficiently with them. We also had an executive steering committee involved to help us kind of make those decisions about timelines and dollars needed to move the project through. So it's really important to get your executives involved as well and keyed into what you're doing and the progress you're making. We did a big bang with our rollout and actually did all 11 hospitals at the same time. As our physicians reviewed the workflows, they felt pretty comfortable that we didn't need at-the-elbow support or videos and other things to teach them how to do it. Pretty explanatory once you get into it. So we basically used the kind of EMR vendor support materials, and we basically just did tip sheets. Basically, here's a new process for getting a dispense history, 3 or 4 slides on that information showing how it worked, and that was really enough to get the physicians on board with it and understanding how it worked from either a nursing staff perspective or others. The other thing we ran into, which is a good tip for everyone to consider how you'd handle it, is the normal setup for at least our email vendor was basically to have someone manually push the button to get this request. So as we worked through it, it was kind of, okay, is it going to be the admission staff when they first come here that would do it? Would they actually push the button? Or is it going to be a nursing staff once the patient gets up on the floor to begin their med-rec process? Do we want them manually pushing the button? In our experience with situations where we allow staff to manually things that we really want to be required is that they don't always do it. And in fact, just even assigning a pharmacy, a third of the time they weren't assigning pharmacies to patients so we can get those electronic prescriptions out the door. So really what we did in the end was basically configure automatically when they've basically been admitted to the hospital, it runs behind the scenes and then it's displayed for whoever would need it going forward. So the nurse or the physician would later see it. It's the same way we've got it set up in our clinics as well. So every evening for those patients that are due to be seen by us tomorrow, the dispense history runs and we can see the medications they've used. By the time they're in the next day, we've already got the information available to them at that point. So consider how you want to do that, and I would recommend that you configure that to run automatically instead of basically allowing for that manual connection. Next slide. This is an example of what it looks like, at least in our EMR. So that insert there shows the medication dispense history as we have it back from a patient. And you can see that there's a number of medications down the left-hand side, which basically would include the name of the drug and the strength. You can see that we've got the quantity filled, and then you can see off to the right the little plus symbols. And those plus symbols recognize and have checked the chart of the patient, look at the medications that they're currently on, and they made a conclusion that these medications with the plus symbol are not in their current chart. So this is a real nice and easy way to basically quickly add those medications by hitting the plus button. That actually takes that medication in the dispense history, gets added into their medication list, so you basically can continue the medication process, reconciliation processes from there. It's very easy to use when it matches exactly on the patient. So basically, if you just got your name, first and last name, and traditional addresses and that kind of stuff, you'll quickly find those patients. And in fact, when we have conversations, really frank conversations like the hypertensive example I gave where we're adding a third medication, patients are really kind of amazed that we've got this information on them and can really kind of help quickly get that conversation going about why they're not taking a medication based on what we've got. We've got ours set for the last 90 days. Ken talked about having a year's worth of information. We wanted to be a little more concise and give me the last 90 days. Obviously, a whole year's worth of patient's medication when there are multiple medication would be a whole bunch of information that might make it more difficult to look at. So we've kind of isolated ours to 90 days. Just another tip on what we've done. And basically during the medication reconciliation process, it really is pretty easy to add that information in. But we're continuing to find that all users of the process of MedRec aren't necessarily aware of it. And so we need to continue to incorporate this dispense history into the workflows that we've got. And actually, we've kind of kicked off some processes more around MedRec recently, and we've kind of defined our process better to include this step. So once you get rolling, you need to continue to promote it and make sure that it gets incorporated in your workflows. That's what we really carefully continue to remind staff about its purpose and really need to promote it. Once you've done your processes, continue to check back in and make sure they're using the dispense history as part of it. They can easily gloss over that step. As I think about our clinic workflows for MedRec, one of the steps are to do that, but they kind of skip steps, and so they're just asking the patient. And we know that just asking the patient, as the data showed from Ken, you can miss many medications. So that dispense history is very important to bring that in. So overall, we've got better data in, which makes a more efficient process for our MedRec. Next slide. So what's been of our experience overall, just in kind of a high level? We get basically performs pretty well. We're getting our medication strength, we're getting the data filled and the filled quantity. Now, in our data feeds, we're currently not getting the SIG or what the directions are for the patient. But you can surmise that frequently for basically medications that are taken on a once daily basis. So if you got a quantity of 30, you can surmise, yes, it's probably once a day. And then at the 90 tablets, that'd be another situation, probably 3 times a day. Be better if that was there, and I know future versions will have that information. But right now, what we've got kind of gives us at least a starting point for the medication that we didn't know they were on. A good first step. Most patients are found by data matching elements, although sometimes pharmacies will add middle initials, or instead of basically the patient's name is Joseph, they'll put in Joe. And so at times we don't always match. But probably the data is there if we were more complete on our descriptions. You know, they go to the pharmacy to say Joseph, they go to the clinic and say Joe, they go to the hospital and say Joseph, they throw their middle initial. Sometimes that information doesn't always match. But overall, in general, we've had very limited outages. It continues to work on a daily basis for us, really not slowed down by any outages, so it's been really good from that perspective. Next slide. As we've kind of got more into MedRec with the meaningful use coming up and all these kind of pieces coming at us as how we perform MedRec better, we really had to step back and say, what is MedRec? We kind of used that term, and we wanted to break down the play into 3 steps to be more clear on what roles could do each step, as well as we really wanted to crystallize on why and what we're doing in each of those. So we've really broken it down based on the Institute of Healthcare Improvements definition, and this is really kind of our MedRec steering committee at Allina's definition. We broke down the play into 3 steps. Collection, basically through a patient interview and maybe a call to the pharmacy, we get the information, get the list generated. So with the dispense history, we can find that information. So that's all the collection step. So you may be varied in who can do that kind of work. So it might be nursing staff, it could be certified medical assistants, could basically do that collection step. Then we need the clarification step. That's step 2. Really looking for what drugs are missing, maybe a psychiatrist prescription out there, maybe there's meds that have been discontinued that we no longer want to have on the chart. We want to assess appropriateness. Maybe the dose might look a little high. We'd want to make a recommendation to the physician to change that. And then sometimes there'll be multiple products and dosage forms in our drop-downs when we're ordering medications where it might have been misordered in the past, and we want to move to the correct medication. So all these building blocks of collection and clarification move that process through. We kind of sign off on that step and move it forward to the physician to basically do the reconcile. So all these information coming at them, psychiatrist prescription coming in, there might be drug interactions now the result of adding that to the chart. All those kind of things need to be resolved by the physician. And the physician is in the best position to make those final decisions. So we've kind of said the physician must do this reconcile step. So you can see when you kind of break down the play, you can really see the individual players and what they need to do, as well as kind of sort things out. Next slide. So based on that definition now, what we're starting to do is we're going further with our steps and processes. In fact, we had nursing doing this work. They were busy with other nursing work and really didn't do as much as we'd like. And in fact, when we did an audit of their work, we still found 2 errors per med reconciliation through the process. So it's really important to kind of get people more involved, and I'll use the term medication experts for pharmacists. We wanted to get them more involved in our processes. And so now in our hospitals, as part of the admission med rec, we have pharmacists involved in that step. And so they're basically doing the collect and clarify steps and then move it on to the physician. So we're basically using the patient's record that we've got in-house. We're using the patient interview, asking them about the medications they're taking. We use the dispense history to kind of fill in the gaps of medications they may have forgotten. And then sometimes we'll even call the patient's pharmacy to provide more clarity. It might be a mail-order pharmacy we're not seeing information on, or it might be a Canadian pharmacy we may have to call to kind of clarify things. So we're still going further, but we're still getting a nice piece of information to help complete the collection step. Basically, the process is improved overall. Basically, we can quickly add medications with the fill date, the medication name, and we can avoid mistakes that we're having with patients saying the blue tablet, and now we can really hone in on by looking at other tools to find which one's blue, and then this is the medication they didn't mention to us, so we can add that quickly. And basically, we can avoid mistakes of typing errors and other things by having a complete history, be able to drop them and bring them all over. Next slide, please. So overall, just kind of our experience, we've got improved medication reconciliation. Again, we've got better data coming in. We know about the psychiatrist prescription. We know they're not filling their medications. It really made our medication addition decisions easier because we knew they're filling those medications from the psychiatrist, for example. And then we're able to detect non-adherence. I talked about the scenario of a hypertensive medication. It also applies to diabetes medication. We've got many goals around our diabetic patient to make sure their A1C, or a measure of their blood glucose levels overall, are in good control. And we can see that when those scores go higher, that in fact they may not be taking those medications. So it's been really good to detect non-adherence. We also think that it improves our patient safety by really knowing what's going on when somebody rolls in and basically is incapacitated. So they've been maybe in an overdose situation of medication. We can quickly use their dispense history to kind of resolve what may be the issue for that patient. Obviously, there'll be other means we'll do immediately when they come in. But these will be clues to us as to what's going on with the patient when they can't tell us what's going on. So in the case of an incapacitation, we can quickly identify what meds they're on and make decisions medically around what's going on with them. Next slide. So in summary, overall, we feel really improves our patient safety because we can reduce the risk of adverse drug effects by really knowing what medications they're taking. More efficient, you saw how easy it is by just a click of a button to add a medication that's currently on their chart versus having someone to hand type it in, understand the spelling, understand there's a blue tablet. All that makes it very efficient. And really it does, as we heard earlier, all the things going on MedRec, really important to have a quick process that meets these quality standards, including meaningful use and what JACO wants us to do. Next slide. So that concludes my formal questions. I believe we're going to open it up for some questions and a post-test.
Correct. And this is Crystal. Thank you so much to all of our speakers for presenting. What we'll do now is start a series of questions in the Q&A function, and folks can do this by utilizing the right-hand side of your screen to submit a Q&A. However, Lauren, if you would go back to the previous screen. I did want to run us we have another series of post-test questions going on, actually one question, and it's a post-webinar question, and it says, is the availability of electronic medication history for hospitals broadly known in your organization? So if you could just click yes or no, and that poll will remain open for the next 5 minutes. And now we'll move on to Q&A. We have a few that have lined up, but once again, please be sure to utilize the Q&A chat function on the right-hand side, and then I'll queue them up for our speakers. We did receive a couple of interesting questions around HIPAA and patient identity, so we're going to start with the hard ones first. Can you, either of the speakers, respond to the following question? What happens when the patient identity does not match the pharmacy database? Specifically, is it informed that the nurse doesn't know there wasn't a match found, and how are those patient med recs done?
So this is Ken Mykowski at SureScripts. Interesting question. When we receive the transactions with the demographics, we have worked with Initiate, part of IBM now, for the last 12 years for both e-prescribing and medication history, to come up with various algorithms for us to appropriately identify patients. If we can't uniquely identify a patient, the message that the technology vendor gets back from us is patient not found. We won't do, for example, we found 3 Patrick Smiths who might live in a suburb of Chicago who, go pick one. That's not the methodology used. We either uniquely identify the patient or we don't uniquely identify the patient. In the case where we don't identify patients, then the medication reconciliation process has to default back to starting the process with the patient interview, or the patient's caregivers, or whatever other method that might be available. Not all patients' medications are in databases. Not all pharmacies participate with providing us data. So there is always going to be a portion of patients who you're not going to get a result back on, and that's going to require defaulting to the manual process.
Thank you. And then let's dig a little deeper into patient information and patient sharing. Does the patient first give permission to the hospital payer and or provider to share their medication history, and how do you specifically address HIPAA considerations?
This is Lee. We decided to move that upstream, and we have an overall consent to the medical records and the use of those. And so we don't ask individually at this step whether a patient consents, because we basically get that consent at the very beginning through many things that we'd want to explore, including charts of different systems. They've been to different locations to be able to bring that information in. So we really kind of moved it upstream. When they are first admitted or they first see us, we'll do that consent process then.
This is Ken at SureScripts. In all of our contracts with our technology vendors, we require that they pass down language in their contracts to their end users, that those end users must follow all local, state, and federal applicable law as it relates to security and privacy. As we are aware, different states have different kinds of consent mechanisms in place, ranging anywhere from notification to triple consent based on where you live. And it's imperative that wherever technology vendors do business, they understand the laws of the state they're doing business in, and then contractually obligate providers to do that. In all cases, as we connect to technology vendors, what we're doing is making sure that the request is being made by a covered entity and that the result is being delivered to a system of record at a covered entity, so that all those appropriate and all the paper trails for BAs and chains of trust between us, technology vendors, covered entities, data sources, etc., are in place in order to make this happen.
So then to go down consent just a bit further, if an electronic service requires to ask for consent before viewing the external and outpatient pharmacy information, is that necessary? And specifically, the participant that submitted the question wants to know, is there an automatic start to get around that?
Again, whether it's necessary is determined by the institution in the state they're doing business in. They need to follow applicable law. HIPAA obviously would be a floor. Some states have requirements over and above notification. We require consent contractually. At the point of admission to a hospital, that's often taken care of at triage. And then that's how an ADT transaction is generated, based on the fact that the patient has been registered, gone through consent, gone through assignment of benefits, gone through the various things that occur during a hospital admission. Obviously, some of that changes in an emergency room where there might be a break the glass situation. But, in general, consent is obtained based on the governing laws of the state the patient is being treated in.
Thank you so much. And I know the consent questions are never easy ones to answer, so thank you. Let's step back then from kind of the admission standpoint, when a patient is found, but what do we do if they have no medication history?
That actually happens if we have a patient who we can only find in the payer master person index. It can occur that a young patient or a patient not taking any medications is in fact a member of a health plan, a commercial health plan, utilizing a PBM, and that patient does exist in that PBM's databases, but if you check the patient's medication history, they're not taking any drugs. Frankly, as a clinician, that may be as important information to me as the fact that they are taking drugs. Now, that obviously doesn't happen in the pharmacy master person index, because if we find you in the pharmacy master person index, it means you've gone to a pharmacy and gotten a prescription filled. So if we find you there, we're going to return something. But there is a situation where you could be a member of a health plan and a member of a PBM, and you don't have any prescriptions, and we would return, yes, we found the patient, there's no medication histories in their claim database.
Thank you. And then one more clarifying question, and it is always interesting. I mean, in the U.S., we don't have a unique patient identifier. So can you talk a little bit more about some of the variables that you put into a unique patient being identified? For instance, name, date of birth, sex. What are some of the variables that you include?
Yeah, the 5 variables we use in our matching algorithm are first name, last name, and any other name components are helpful. Middle initial, prefix, suffix are all valuable, but in general, first name, last name, date of birth, gender, and zip code.
Thank you. And then I do have a question about the data and how we could potentially export that. So is information from personal health records available, or is that used along with checking the electronic medication history?
SureScripts doesn't query personal health records. It queries pharmacy claims, PBM claims databases, and pharmacy clinical data repositories from retail pharmacy. Lee, maybe you can, once again, and if you remember my chain of trust as getting the medication history to a system of record and a covered entity, so once it gets to an IDN that uses an enterprise system, and that enterprise system has associated with it a patient health record, if that clinician wants to now share information that we provided that now is in that patient's record as a covered entity to the patient via a patient health record, they certainly can. If they have the ability to query patient health records, that would be a separate query outside of coming to SureScripts for medication history. SureScripts doesn't share medication history today with patient health records relating to many of the things you've already talked about, including things like consent and authentication and identity proofing, etc. we share with covered entities and count on that chain of trust to share with patients if the clinician so desires.
Thank you. And did our other panelists want to comment on that?
Yeah, we've got basically patient portals that they can look into their chart and see the medications they're on. But outside of our EMR record, we're not pushing data outside of that either.
Yeah, this is Shelley. I'd just like to also mention that the Blue Button Initiative is available, and there are some pharmacies who have taken up that initiative, especially some of the chain pharmacies, to add the Blue Button capability where the patients can download their information, their medication information, into their electronic health record. So if you are interested, there is some information on the ONC website in relationship to how a patient can access that information, how providers can also become part of the Blue Button Initiative.
Yeah, and I would further add that, you know, PBMs and pharmacies have allowed access to electronic medication history to their customers and members via their websites for years. So I think Blue Button is now bringing, this specific initiative is bringing light to the fact that that information is available to patients at any time and has been for many, many years. And I think it's bringing good light to the fact that patients can access this information now.
So since we started on the conversation of data exchange, whether it's patients or another entity, we did receive a couple of questions about HIE's Health Information Exchange. One of the questions that we have is there an opportunity to connect with health information exchanges, including RIOs? And then the second question was, is there an opportunity for providers from the HIEs to ping to obtain this information?
Well, this is Shelley. I can go ahead and take that on. It depends on the state HIE or a regional health information or regional health information organization of what actually is available and how you can obtain information. We do have instances where there are state HIEs that do make medication information available to hospitals and to physicians' offices and even to pharmacies in some cases. So there are processes. You have to realize, again, going back to the source of the information, and is it a trusted source? So, and there are many pilots that are out there that are looking at combining not only, you know, traditional med history information, which is coming based off of medication claims information, and also combining that with information that might be a little bit more specific in terms of a reconciled medication list that might come through as a discharge summary, or other types of structured documents that are being used to electronically exchange an active medication list. So there are different sources of medication information, and health information exchanges, including the RIOs, do play a piece in this puzzle.
This is Kenneth Schersker, and we do participate with some health information exchanges, but again, you know, the key for us is making sure that it fits within the data rights of the data sources we provide data from. Again, it goes back to the ability to have all the appropriate contracts in place as far as BAs and covered entities go, and at the end of the day, we still, even if it's through an HIE, need to deliver that medication history to a system of record at a covered entity. And if that relationship exists, we can work with an HIE. If that relationship doesn't exist, we probably can't.
Thank you for answering both those questions. We've received another question going back to it about 10 minutes ago around patient consent again. And the submitter's question was that, is patient consent simply a yes or no that is being defined here? NCPDP is supporting a few different patient consents within the standard, and the person who submitted the question is trying to understand the gap.
So patient consent, again, is more related by local law. So HIPAA is the floor, and then anything above that would be local or state related. So there may be states that only require notification. There may be states that actually require consent. We actually require consent that, yes, the patient says we can get the medication history. If you go to the state of Rhode Island, they have a triple consent mechanism for their HIE. It really is dependent on where you are in the country and how your law is interpreted by your IDN. I'll give you a personal example. I live in St. Paul, Minnesota. I go see an internist at an IDN in St. Paul, and every time I sign off, when I register, I sign off to a specific line asking me about medication history. I went and saw a specialist across town, same state, different IDN, and I signed off for lifetime consent on all exchange of data, not specific to anything in general. So how laws are interpreted by the legal teams at specific IDNs and in specific areas of the country are based on how they interpret the law. We require that they follow all local, state, and federal laws that relates to security and privacy.
Thank you. Again, and we can make some more information available along with the slide sets around privacy and security. I know several organizations, including HIMSS, has privacy and security toolkits and additional resources to help the several questions that we've received on this topic. So let's switch for a bit. We do still have about 15 minutes left, so I would encourage folks to incorporate and suggest some questions for our panelists using the Q&A function. One question that came in, and I just lost it. Okay, I found it, is in regards specifically to the information and data that's being provided. So in your opinions, do the majority of large hospital IT vendors supply both pharmacy benefit management data as well as pharmacy claim data?
Somewhat dependent on the technology. We have, SureScript has connectivity to a variety of large EMRs as well as a multitude of technology vendors with medication, who do medication reconciliation. All of those who have an HL7 interface with us receive both pharmacy and PBM data. We have a different implementation with a large EMR that is now moving towards both of those data sources with their next version of the product. So that will happen over a next period of time, but that's more of an exception to the rule than the rule itself. In general, anyone who's done an HL7 implementation to us has access to both data sources.
Excellent. And then we did receive another question around data sources. The person who submitted the question asked early on, and I believe this was during our second presenter, to clarify, are cash non-pharmacy benefit management transactions included in pharmacy fill data?
Yes, they are. So, and I think the other thing to point out is that the medication history we get from both PBMs and pharmacy is not related to whether or not that prescription got to the pharmacy electronically. It could get to the pharmacy any method, walk-in, fax, whatever. But yes, cash pay medications provided at that pharmacy would be provided in the dispensed history. And as I've said, they may also be included in the patient's claims database if the pharmacy knows that the patient is paying cash but also has a benefit. Pharmacies tend to adjudicate a claim irrespective of whether or not they're receiving payment from the PBM rather than opt out because it's more difficult to do that. So cash pay medications can appear in claims databases as well.
Thank you. Now let's shift gears a bit and talk a little bit more about meaningful use. And Shelley, I know that you had provided us with quite a bit of information about that, and then I know our other speakers did as well. One of the questions that came in is the information that was provided today does sound interesting, but it seems like it might be an add-on. When we think about meaningful use phase 3, to what extent do the panelists feel the functionality that we've discussed today will be included as a standard feature of EMR and pharmacy software?
Well, I'll take that on first, and then I'll let the other speakers add to that. But as far as meaningful use stage 3, the biggest focus right now that is being discussed is in terms of patient safety and in terms of patient engagement. And with medication history and actually even reconciling medications, those are both a patient safety and a patient engagement issue. So I truly believe that as we move forward with more clearly defining clinical quality measures related to medications, I personally believe that this will be an issue that will be looked at. Now, in terms of what they've already addressed as proposed in terms of medication history for helping with med adherence, I think is another aspect that has become important, mainly because hospital readmissions is a way to measure that a patient is compliant with their medications and keeping the patient out of that hospital. So because it is a way to actually put a dollar figure to misadherence and misadventures, that it is a potential source of becoming a quality measure. And I think that that's one of the reasons why it was added, because med adherence is such a major focus, not just in dealing with meaningful use from a CMS or Medicare standpoint, but even in private insurance, it's becoming an issue. And so I think going forward in the future, because of the patient safety and because of patient engagement, I think that we will see terms in relationship to medication reconciliation, med adherence.
Thank you. And Ken or Lee, did you want to comment on that?
Yeah, I believe, this is Lee, I believe that it is optional for our EMR vendor to add at least on the hospital side. But I think we painted the picture today that really shows that it's of value to add it, and really as part of the collect step, you really need to have that external source coming in to kind of verify what's going on with patients. As we saw from the data that Ken showed, many patients forget all the medication they're taking. So that's a key step to be able to have a adverse drug event free visit to a hospital by making sure you're fully aware of all the medication the patient are taking.
And during a patient interview, if a patient's taking their medication 60% of the time, and you ask them, do you take your medications, their answer is going to be yes. And they're not lying. Having them now quantify that to 60% is a very difficult thing to do. The one aspect of the attributes of electronic medication history is it is longitudinal in nature. So yes, you can see that patient does take their drug, but if they're antihypertensive or if they're anti-diabetic, and they are only taking it 60% of the time. And that has the potential to impact treatment. If you look at meaningful use criteria as they move forward, obviously they're related to having an electronic health record and utilizing an electronic health record. And as you see, it goes from not only having it, using it, and having exchange, but creating quality and creating information that is actionable. And without an electronic health record or some electronic product, it's hard to do the analytics manually that a health record can provide in order to provide the information necessary for the clinician to help make better decisions. So I think it will happen. Meaningful Use 3 is in proposal. Whether it happens there or the next set or the next set, I'm not sure, but it makes sense based on the fact that meaningful use is related to electronic health records.
And I'll just add something else. Our experience with meaningful use is that basically it was just, did you review the med list, and then basically you click yes, and that was the extent of it. We were very high at that. but did we really account for all the pieces and really kind of do the collect step the way you need to? And in fact, I don't think we were. So it was so easy just to click that button, we reviewed the chart, the medication list, and that would meet the measure. So I think if you look at the process and understand what you're trying to do, that collect step is critical to making the final med rec step complete.
Excellent. And we are closing out on about 10 minutes left, and we have gone through all the wonderful questions. So I wanted to give each of our panelists an opportunity to provide us with some words of wisdom or anything else that they didn't get to address. And I would like to start where we ended. So Lee, if you would start and just give us any closing remarks or words of wisdom that you would like to share with the audience.
Yeah, I'd say that once you get it up and running, really kind of continue to work with your MedRec teams and assure that this step is part of your process and really called out very succinctly with even screenshots of information that it shows. So, and then continue to promote it. I continue to find physicians that don't know about it yet, and so I need to promote that piece. So get it incorporated in your MedRec process and promote it, that it's available, because I think it's a nice piece of information. Thanks.
Thank you. And Ken?
Yeah, thank you, Crystal. I think mine is more a word of caution. As I've been in health informatics for 14 years now, one of the things that I always like to bring back is that don't expect the digital world to totally replace what it is that you need to do as a clinician. This doesn't replace responsibilities of clinicians to do medication reconciliation. It helps start the process. It scares me every time someone says, well, the computer said that's what you're taking, so that's what you must be taking. So I'm throwing in the little bit of grain of salt of always making sure you've got the right patient in front of you, make sure you go through the process with the patient, add in other drugs. It isn't a replacement. It's part of starting a process, but the process still has to occur.
Great. And then Shelley?
Thank you, Crystal, for a great program. I'd just like to close in saying that from a patient safety standpoint and from really trying to engage our patients, as pharmacists, it's really important that we play an active role in medication reconciliation. And doing this electronically, just as Ken had said, is important, but we have to be able to trust the information. But we also have to be able to share that information. So especially in our hospital situations, we need to make sure that pharmacists may not be the ones doing medication reconciliation, but we have to play an important role in how that medication information comes into our hospitals and how it's going to be actually shared with not only the healthcare providers as they're leaving that hospital situation, but also with the patients themselves. And as we move to that electronic environment, it's important that the information be trusted, be a good source of information, that we're meeting all the consents of the patient. Because if we can do that, we're really going to save our patients from some really bad things that can happen to them. And that's where the patient safety really comes in. I just want to thank you for hosting this today and for inviting me to participate.
Absolutely. And with that, we'll run through a couple of housekeeping items. So I just wanted to remind all of the attendees for today that the slide as well as the recording information will be made available and it will be complimentary. Please visit www.hims.org/library/pharmacy-informatics to download today's slide deck as well as our previous slide decks and access the recording of this session. If you lose that URL, you can easily go to the hims.org website and Google Pharmacy Informatics or Pharmacy Town Hall, and the information will pop up. I also wanted to remind all of our attendees today and anyone who is listening on the recording to save the date for our future town hall, which will also be brought to you by HIMSS NCPDP as well as sponsored by SureScripts. Our next town hall will take place on Thursday, April 10th at 11 a.m. Central, and we will be discussing the new standard for electronic prior authorization. You can register on the Pharmacy Informatics website, which is www.hims/pharmacyinformatics. And thank you again to all of our attendees today, and a big warm welcome, or big warm thank you to NCPDP, SureScripts, and today's speakers, Ken, Shelley, and Lee. With that, we will conclude today's presentation. Thank you.